Good morning everyone. I am Dr. Kunal Desai and today we will be continuing our discussion on tobacco use disorder. So this entire presentation will be MCQ based and we will just be testing the knowledge which you have acquired so far and adding a bit to that. Plus it will be more interactive I thought, but since you guys won't be able to discuss this with me, what we'll do is after I read out every MCQ and the options, we'll wait for let's say 10 seconds. You can think up the answer yourself and then we'll proceed to discussion, right? Okay, so number one. A chronic smoker taking 20 cigarettes per day has developed chronic cough. His family suggests quitting cigarettes and he is ready to quit, but thinks that quitting cigarettes will make him irritable. Which of the following options best describes the stage of behavior change? A. Pre-contemplation and preparation. B. Contemplation and cost analysis. C. Persuasion. D. Belief. Alright, so if you have studied substance use disorders, which I believe you have, then you must know about Prochaska and De Clemente's stages of motivation, right? So pre-contemplation, contemplation, action, maintenance, relapse, these are all the stages. And in this particular MCQ, we are talking about a chronic smoker and who wants to quit cigarettes. He is ready to quit, but he is worried that it will make him irritable, so he is still not completely convinced. So let's look at the options one by one. In pre-contemplation and preparation, the patient is not ready to quit. It is still pre-contemplation. He is not thinking about how he will quit and the steps he will have to go through. So that is the wrong answer. Option B, contemplation and cost analysis. Now this is the right answer and we'll come to this later. Options C and D are not technically stages of motivation given in the Prochaska and De Clemente staging. So that eliminates it. Right, so even by eliminating C and D, we are left with only B. But contemplation implies that you give an active thought to how you are going to go about this entire process, and then you are thinking about the pros and cons, what problems am I likely to encounter when I start my de-addiction process. So the answer is option B. Question 2. What is the half-life of nicotine? A. 1.5 hours, B. 2 hours, C. 30 minutes, D. 4 hours. Sorry for the interruption. Hopefully you guys had enough time to think. So this is a straightforward question and the answer is 2 hours. It's the elimination of life of nicotine, something you just have to remember. Right? Moving on. 3. What is the mechanism of action of Varenicline? A. Alpha 2 beta 4 nicotinic receptor agonist. B. Alpha 4 beta 2 nicotinic receptor partial agonist. C. Alpha 2 beta 2 nicotinic receptor partial agonist. Or D. Alpha 4 beta 2 nicotinic receptor agonist. Alright, so this is another straightforward question. something you need to remember, the names of the major receptors on which nicotine acts. So there are other receptors besides this, but this is the primary receptor of nicotine, and Varenicline acts as a partial agonist on this receptor. Now we have two options for partial agonist, and the correct answer here is B, alpha 4 beta 2 nicotinic receptor partial agonist. Which of the following drugs is not used to treat tobacco dependence? E, Naltrexone, B, Bupropion, C, Varenicline, D, Acamprosate. Alright, so you have to be very careful in these not negative questions. So this always becomes a process of elimination, such questions. So A is Naltrexone, we'll come to this one later. B is Bupropion. This is a drug used to treat tobacco dependence, right? It is an NDRI, noradrenaline dopaminergic reuptake inhibitor, which is also used for tobacco de-addiction and as an antidepressant. Then there is Varenicline, which we have just discussed, right? It is a partial agonist at alpha 4 beta 2, so it is used. Now we are left with A and D. So A is Naltrexone is an opioid antagonist, right? So you would think that, okay, then its primary use would be in opioid detoxification. You are right, it is used there. It is also used in alcohol detoxification. Now it is also being researched for tobacco detoxification, tobacco de-addiction, sorry. So this option is a bit controversial because it is not very commonly used for tobacco detoxification, but it is still used. So since the question is which is not used, we are left only with Acamprosate. Acamprosate is used for alcohol de-addiction. What percentage of tobacco users become dependent after the first intake? 30 to 40%, 10 to 20%, 50 to 60%, 70 to 80%. I think all of you must get this one right because this question was discussed in the previous presentation, right? So this is another factual question. The answer is 30 to 40%. It is roughly 33%. So you can remember that 1/3 of every person who tries tobacco will become dependent even after the first intake. It is that addictive. It is the most addictive. It is a substance with the most addiction potential, right? Which is the most commonly abused form of tobacco in India? Cigarettes, Bidi, Gutka and Hookah. So this question is actually very simple if you think about it, and again we can proceed by elimination. If you look closely, A, B and D are all smoking forms of tobacco, while only C is a smokeless form of tobacco, and smokeless tobacco is the most commonly abused form of tobacco in India, which leaves us with the answer C, Gutka. Which of the following is not a tobacco product? Khaini, Doda, Mawa and Misri. Okay, so this is somewhat related to the previous one because if you will have observed A, C and D, Khaini, Mawa, Misri are all smokeless tobaccos, and so by elimination that leaves us with B. Doda is an indigenous preparation of opioid and it is commonly found in Rajasthan and like as you go north from there and in areas of North Gujarat as well. So you might not be familiar with the name here, but even by elimination you can reach this answer. Which of these, this is a mistake, which of these has the best quit rate for tobacco dependence? Self-quit, gum plus patch, medication plus advice and behavior therapy. Alright, so let's go through these one by one. Self-quit is, you must use common sense here. It has the least chance because without any external factor motivating the patient to prevent relapse, it is not very likely to work. So A is out. B, gum plus patch. Now you have to use your heads here. Even the option itself seems flawed. Why would you use gum and patch at the same time? They are both nicotine substitution, right? If you want to use one, you should, if you want to use nicotine substitution, you can simply use one of these. But again, okay, let us keep it an option. Then we have C, medication plus advice, and D, behavior therapy. Now, behavior therapy by itself does not have very good results. This is just something which has been seen in practice, so it is out. Medication plus advice is a very broad answer, but it will include Bupropion, it will include Varenicline, and they have very good results. Now, it can also include patches and gums actually, because medication, as I said, is a very broad term. So that along with advice, like we say in any psychiatric disorder, pharmacotherapy plus psychotherapy has the best result. So it is the rule here as well. Medication plus advice is the answer. By the way, that last question was asked in the recent NIMHANS exam. Which of the following scales is used to assess severity of nicotine dependence? SIVA-AR, SIVA-B, Faker-Strom, and Cowes. Okay, so this is another factual question, and you have to have read about these scales. I think all of them, you need to know what they are to be able to figure this out. So SIVA-AR is Clinical Institute Withdrawal Assessment, Alcohol Revised. So it is for alcohol. SIVA-B similarly for benzodiazepines. Cowes is Clinical Opiate Withdrawal Scale. It is used for opioid withdrawal, as the name suggests. So that leaves us with only Faker-Strom. Faker-Strom scale is used for assessing the severity of nicotine dependence. What is the typical dosage range of nicotine containing chewing gums? 2 to 4 milligram, 4 to 8 milligram, 1 to 2 milligram, and 8 to 10 milligram. So I think all of you must have at some point or the other seen those boxes of Nicotex chewing gums, and 2 to 4 milligrams is the typical dosage range. So we use multiple such gums every day. It can go as high as 10 or 12 or even 15 per day, but the dosage strength of each of those chewing gums will be 2 or 4 milligram, depending on how much tobacco consumption the patient is currently undergoing. Which of the following is not a symptom of nicotine withdrawal? Restlessness, meiosis, insomnia, difficulty in concentration. So if you have a basic knowledge of pharmacology, you should know that meiosis has very specific mechanisms. Like you can have a muscarinic receptor agonist action, or you can have adrenergic action, right? That will lead to meiosis. Apart from that, nicotine as such does not cause meiosis even on application or on withdrawal. So by that knowledge you can get this answer. Or if you know that restlessness, insomnia and difficulty in concentration are the symptoms of nicotine withdrawal, you can reach the same answer through that. Which of the following is a contraindication for Bupropion? Ischemic heart disease, hypertension, epilepsy, and diabetes mellitus. Okay, so this is something very specific for Bupropion. If you have read about Bupropion, you will have noticed that one of its dangerous side effects is epilepsy. Now, one thing we should specify here is that this stands true only for Bupropion immediate release, IR. In sustained release Bupropion, this problem has not been seen. So, from that we can deduce that epilepsy patients who are already already susceptible, who have a lower threshold for seizures, would be poor candidates for Bupropion, at least the IR one. So answer is C. Drug de-addiction program and drug treatment clinics are under the purview of which ministry? Social Justice and Empowerment, Health and Family Welfare, Finance or Home Affairs? This is another question which was asked in the recent Niman's exam. So obviously it is a factual question. The answer is Health and Family Welfare. Now you might be able to deduce it through common sense, since it has to do with drugs and treatment of drug addiction. It should be Health and Family Welfare. But why it becomes confusing is that there is a similar agenda of drug reduction. So the drug reduction program regimen, that falls under Social Justice and Empowerment Department. So you can remember it this way, that when we are talking about de-addiction and treatment clinics, like once the addiction has taken hold, we go to Health and Family Welfare. But when we are talking about prevention, or let's say rehabilitation, the drug usage reduction program, that falls under Social Justice and Empowerment. The answer here will be B. Through what pathway in the brain does nicotine create its addictive effect? Midbrain to ventromedial prefrontal cortex, midbrain to dorsolateral prefrontal cortex, hypothalamus to pituitary, or ventral tegmental area to nucleus accumbens? To answer this question, you need to have at least a cursory knowledge of the dopaminergic circuits in the brain, the addiction pathway. So ventral tegmental area of the midbrain and nucleus accumbens to nucleus accumbens, that is the final dopaminergic pathway. It gets activated in all addictions, behavioral as well as substance addictions. So that should create that a hint in your mind. So it should flick on the light bulb that okay, maybe something to do with addiction, so it should be this pathway. Apart from that, if you know what the other pathways do, like all these three other pathways are other dopaminergic pathways which we study specifically for schizophrenia, then you can do this entire thing through elimination as well. Right? So the answer is VTA to nucleus accumbens. Which of the following is not an example of polysubstance addiction? Alcohol plus tobacco plus amphetamine, alcohol plus opioid plus tobacco, alcohol plus tobacco plus caffeine, and alcohol plus cannabis plus caffeine. Polysubstance addiction is actually an outdated term now. It was used in DSM-4. It has not been mentioned as such in DSM-5. But you should still know what it means. So polysubstance addiction means using three or more substances, being dependent on three or more substances at the same time, excepting tobacco and caffeine. So they do not fall under the purview of polysubstance addiction. Like you might have, I said three, right? It is two or more substances. Two or more substances excepting tobacco and caffeine. So looking at these options, A is alcohol, tobacco, amphetamine. So alcohol and amphetamine, right? So that is polysubstance. Alcohol, opioid and tobacco. Alcohol and opioid, right? So polysubstance. Alcohol, tobacco, caffeine. So we have only alcohol here. So this is the right answer. And D is alcohol, cannabis. So plus caffeine. So alcohol, cannabis make it polysubstance. So answer is C. Alright, so we are done with the MCQs. And since there is no scope for discussion, if any of you have any questions, you will personally have to contact us at the psychiatry department, I suppose. Alright, thank you.